So welcome to this session of Heart Café. It's going to be cardiovascular complications and the flu. Is vaccination the answer? My name is Pablo Perel. I'm the Senior Science Advisor of the World Heart Federation. I'm a cardiologist and professor of clinical epidemiology. And I'm very happy to have a really stellar group of experts on the topic. Professor Eileen Handberg. She's professor of medicine and director of the cardiovascular clinical trials program in the division of cardiovascular medicine, University of Florida. And she's also president of the Preventive Cardiovascular Nurses Association. We have also Professor Keith Ferdinand, professor of medicine, Gerald S. Berenson Chair in Preventive Cardiology, Tulane School of Medicine. And we have Professor Álvaro Sosa Liprandi from Argentina. He's the president of the Inter-American Society of Cardiology and head of cardiology at the Güemes Hospital in Buenos Aires, director of the Graduate School of Cardiology at the University of Buenos Aires. So thank you for coming. Thank you, ACC, for giving us this space for these conversations. Also, thank you to Sanofi, who sponsored this event. And it's going to be, as I said, I hope an interesting and informal conversation. I will start asking some questions, maybe to all of you. Maybe I'll start with you, Álvaro, first. And I'll start with a question about effectiveness. I think probably we agree, but I want to spell out that from the beginning. What is the current consensus regarding the use of influenza vaccination in people with cardiovascular disease? For which population we have enough evidence, and it's very clear, or is any cardiovascular disease population for which the evidence is more limited and we still need more clinical trials or research?
Okay, thank you, Pablo, and thank you so much for this kind invitation and give the opportunity to give my perspective about this very important topic, particularly for us, for the cardiologists. And really, we have a very robust and very important evidence that support that immunization and particularly influenza vaccination have a very important role in terms of cardiovascular prevention, cardiovascular prevention in terms of cardiovascular event. It's so clear that patients with coronary artery disease or patients with many other different cardiovascular conditions like heart failure clearly have a very important benefit when you compare the people who receive versus the people who don't receive vaccination. And particularly if you are talking about influenza, obviously there is a very strong and very robust evidence about the reduction in terms of cardiovascular event, including mainly mortality. This is very, very impressive when you compare in patients with coronary artery disease who receive or don't receive vaccines, independent, including of the age, because obviously a very important people who benefit with influenza is people older than 65, but in patients with cardiovascular condition, independent of the age, the difference when the population receive or don't receive is so clear and very impressive. And at the present moment, we don't have doubt about that this kind of patient must receive this kind of intervention, particularly immunization. Because when you compare, for example, the impact in terms of effectivity from vaccines, when you compare with other very classic intervention like reduction of control of hypertension, reduction of cholesterol or smoking cessation, the impact of the intervention, the impact of the intervention of vaccination is included higher than this classic intervention. That is so clear in this kind of population. The main concept is that we have randomized clinical trials, we have a lot of observational clinical trials, and really the evidence is so robust.
Thank you, Álvaro. I don't know if Keith or Eileen, you want to add anything to that?
Yeah, I would like to add that when you look at people who we treat for cardiovascular disease related to age, hypertension, chronic kidney disease, other inflammatory diseases. These are the same persons who have higher death from influenza. The virus does not just inflame the respiratory tract, but it also inflames the vasculature. And we know that atherosclerosis is not simply a passive buildup of cholesterol in the blood vessels, but it actually is an inflammatory response. Hence some of the data showing the direct relationship between high sensitivity C-reactive protein. We know of the data, although it may be flawed, using colchicine in persons post-myocardial infarction. So it's not surprising that especially in high-risk patients who are infected with the flu, while they may still have respiratory symptoms, most of the mortality that you spoke of is directly related to acute myocardial infarction and even stroke post-influenza. And that drove my interest as a cardiologist and a person who has dedicated his life to community interventions to start to migrate along with blood pressure screening, cholesterol screening, to helping my patients understand the need and my community understand the need for influenza vaccination.
But I think that the gap is that patients don't understand what you both just said. Patients don't understand that a single flu vaccine can make as much difference as controlling blood pressure in terms of risk reduction. And so I think we have a lot of opportunity to develop infographics for clinic practices so that patients understand that it's not just, I mean, there's a lot of vaccine fatigue. And so that people, especially those with cardiovascular disease, understand the true benefit to having that vaccine every year. And I don't think we recommend it all the time in practice, but I don't think they understand the true benefit. And I think that's a gap in our ability to educate our patients so that they understand.
So interesting. We're moving already to, I mean, one of the key things that I think we're going to be discussing, that is, we know that it works, but is it being implemented? And if not, why, and what can we do about it? But before moving into some of the recommendations, maybe, Aileen, you can tell us what's the uptake, for example, in the US of vaccination?
Yeah, so the CDC data that came out at the end of February, about 47% of adults in the U.S. will be vaccinated, which is up about 3% from last year. So there is some uptick, but there's huge variability from state to state. And we still have this issue of disparities in terms of, so for Asians, 49% of them are vaccinated compared to only 38% of African Americans. Hispanics is even lower at 35%. The uptick in patients who are over 65, which is the demographic of a lot of our cardiovascular disease patients, is as high as 71% in the Caucasian population, which is better than it was last year. But there's about 31 million people in the U.S. who do not intend to get vaccinated. So there's a lot of opportunity here. Overall, last season, about 54% of the population got vaccinated. So half or not. And so if we're talking about, and only last season, only 40% of African Americans got vaccinated. So there's a lot of opportunity here.
Yeah, I think that's probably one of the main focus of this, why this is still happening. And I know, Keith, you've been working on disparities for a long time. Maybe you want to expand on that and also, share your thoughts about some of the drivers for these disparities.
Yeah, we have a nonprofit organization. I work at Tulane, which is an academic center, but part of my community work is through a nonprofit known as the Healthy Heart Community Prevention Project. And just this fall, we took on influenza vaccination as one of our major interventions. We called it NOLA Flu. NOLA stands for New Orleans, Louisiana. So how do you do that? Well, you have to get partners. It's not going to be the clinicians or the academicians who are going to drive this. You have to work with the ministers who have the faith-based institutions. work with the community hospitals, not the big hospitals downtown, but the smaller hospitals, work with other organizations, PCNA. My personal nurse practitioner was part of the team. Chloe, you know Chloe?
Yes, well.
And we went to some novel places in order to drive flu vaccination. We went to local hospitals. We went to parks, outside in parks. We went to something called community centers. There are these places, especially where older individuals will come to do daytime exercise and play bingo and do those sorts of things. We went to those centers and we were able to show a significant uptake because we were there on site, more than waiting for them to come for the magic doctor's visit, which, as you know, is often 1, 2, or 3 times a year. And if the physician has not appropriately done influenza vaccination sometime in the fall, then it may be into the spring until they see that patient again. So we went into the community, into the churches, into the parks outside, into the community centers where the older people come for their daytime activities, and did influenza vaccination in the community sites.
Yeah, that's so important, and I think that experience of going closer to the community. I mean, sometimes we forget about the importance of that. But I would like to hear from Alvaro. I mean, you recently led a consensus for the region, for Latin America, with the Inter-American Society of Cardiology and the World Health Federation on this topic. And what are the challenges in the region in terms of uptake? And what did you find? And maybe what are some of the recommendations that you came in that consensus?
The most important challenge is obviously is the very low vaccination rate in many different regions. And really this is it's an important challenge in our region in Latin America, but it's an important challenge all over the world, because when you analyze the vaccination rate in different regions of the world, it's really amazing the disparity in different countries. If you look Latin America, for example, there is a great disparity when you compare countries with, for example, with tropical climes. When you compare what happened or what is the vaccination rate in this kind of countries, and you compare in other situation, in other kind of countries. For example, the vaccination rate, the disparity is between 10% to 80%. It's really an amazing difference. And I totally agree with the approach to obtain an increasing of the vaccination rate, but it's very important to remind that when you analyze the missed opportunities of vaccination, one of the most important missed opportunity are related with our conviction, the conviction of the doctors. This is very important topic too, because the majority of the missed opportunities of vaccination is the no prescription at the moment of the medical visits. This is very important. We need obviously many action in the community, but we need many action in terms of education to the medical education. It's very, very important, because it's really impressive that the main missed opportunity at the consult at the office of the doctor.
Thank you. And you talk already, and I'm sure people here, if you are interested in this topic, you want to have some ideas of how we can improve this. So we know that it works. We know that there's still an important gap and disparities. So we already mentioned things going more on service delivery, so going closer to the community. We talk about healthcare providers, so education and being an ambassador, an agent for that change. Anything else, maybe from a public health perspective, from any other suggestion, solution to improve the situation?
Well, first of all, I agree with you that if you're in the fall period into the early winter, even where we are now in early spring here in New Orleans, I guess it's winter elsewhere. And where is it in Argentina? It's summer? It's summer. Depending on the season, that during the regular clinical visit is the best time. That person should not have a blood pressure and a temperature and a weight and not get the offer of flu vaccination. The other barrier that I think we have is the misinformation that's on Twitter and Instagram that flu vaccines don't work because you can be vaccinated and the penetration of infection is as high as 50%. So they say, well, it doesn't make a difference, it's a flip a coin. But what's being missed is it decreases hospitalization and death. You may still get an episode of influenza, but you won't be hospitalized, you won't die. So it's not a magic bullet, it's not a coat of armor that stops the influenza virus from entering the body completely, but it does diminish the severity of disease.
Well, and I think, in the U.S. particularly, the delivery of vaccines in pharmacies has really increased, and the data from the CDC would suggest that that's a more popular way to get vaccinated than being in the doctor's office. So even if we miss it at the visit, there is the opportunity to get access a lot easier. And there's a CVS and a Walgreens on every corner in almost every community, especially across the corner. So, I think that helps. I do think that there's a big missed opportunity across the nursing profession. There are 27 million nurses in the world. And if you think of the number of people that nurses touch, there's a lot of opportunity to mobilize that boots on the ground workforce to improve the understanding about vaccines, flu vaccine particularly, and to try and encourage that. And this gets back at going back to the community and trying to harness the energy that we have. I mean, one physician can only make so much impact. But when you talk about 27 million nurses, if each one of us touched 5 people, can you imagine the number of people that we might be able to do? And I think COVID was a great petri dish of understanding about what the true potential was for vaccination in the world. I mean, if you think back a year and a half ago, how many of you drove up in your car to a parking lot and got your vaccine and were in and out in 5 minutes, and the number of vaccines that were delivered in a very short period of time? And we have the capacity to do amazing things in the vaccine world. And I think COVID allows us to see some of that in action. And I think that there's probably an opportunity to think about that in the flu vaccine on the annual basis in doing that in a different way.
May I build? So we're hearing 3 different things, but I don't think they're competing. In the usual clinic visit, during the appropriate period, depending on where you are in the world and the time of the year, the flu vaccination should be a part of the internal medicine visit or the cardiology visit. We agree on that. I actually also agree that in the United States, and I don't know how it is in South America, you now can get flu vaccines distributed directly into the local pharmacist, which is in the community. In fact, I was vaccinated this year at a local pharmacy. It's easier. You don't have to call and get the appointment and sit in the waiting room reading bad magazines for 2 hours.
That's right.
You walk in and get your flu vaccine and you're gone in about 10 minutes.
That's right. You buy your other stuff.
So I agree with that. But especially in the African American community where you have a lot of distrust and outright mistrust. They don't like doctors. They don't trust doctors. When I go as a community person, because I don't go as Dr. Ferdinand, I go as Keith. And when my nurse goes into the community, she's from here, and the minister holds it at the church, we can do several hundred people at one time. And I think in that one particular setting, we can beat the doctor's office, maybe not compete across the whole season with the local pharmacists, but in terms of an intensive outreach, we can even beat the local pharmacists.
Just 2 comments. One of these is I'm totally agree that the the very important, tremendous role of the nurse in the objective of to increase the vaccination rates is absolutely, I am totally agree that is a very, very important role. But I want to mention that very recently, or 2 years ago, we have the opportunity to know the results of the YAMI trial, an impressive trial that checked the hypothesis that you can get immunization, influenza vaccine to patients with coronary artery disease in patients with acute syndromes, acute myocardial infarction. There is an impressive difference in the people who receive during in the coronary care unit, received the vaccine during the care unit during the first 72 hours after an acute myocardial infarction. The difference of the population is very impressive. The reduction in cardiovascular mortality and total mortality is in this kind of population near to 40%, impressive. And I really think that the admission to the hospital of the patient with coronary artery disease, with coronary artery syndromes, with acute coronary syndromes, represent a great opportunity to prescribe vaccination. And it's very important to compromise the people who work in the coronary care unit and in the hospital. Because as you well know, the prescription that you make to the patient during the admission represent a very important adherence in the next month. And really, I think that the interaction of the doctor and nurses during the admission of the hospital in this kind of population represent a great opportunity to increase the vaccination rate.
I think I agree totally, but I think this is a movement of thought in cardiology. I mean, in the past, vaccination was an outpatient public health thing. And so training our trainees to think differently about everything that we do on an inpatient admission and vaccination is a reason why the House of Cardiology has to be more involved with this. This is not just an outpatient public health issue, it's an inpatient, and it's a collaborative in an outpatient effort. And you're right, if we could capitalize on that teachable moment and the intervention with all the things that we know, make them, it doesn't have to be all the high-tech stuff. It's not, the 15 stents, but a vaccination could make as much difference in outcomes. And so why wouldn't we do that? Why wouldn't that be on the order set for every ACS patient? And the people in the audience could clearly go back to their institution on Monday and look at your acute MI order set and look and see, are those patients being assessed? Are they vaccinated for flu this season? Should they be while they're hospitalized? And individuals here from this meeting could go back and change practice on Monday.
Thank you. And I think it's great. You are already getting a lot of very concrete recommendations on things to be done. And start thinking about a question you would like to ask the panel. So I'll ask a few more questions, and then you have time to ask your questions. And I was wondering, if this is not part of the problem, at least from the cardiologist community, that, this will happen after they are discharged. Influenza, it's effective, but it's not our business. And I think there is definitely a role in terms of education, and it's good that we're having more of these spaces in Congress of Cardiology. And you mentioned a few things on service delivery already, but I also wanted to ask about other aspects of the health system that it wasn't mentioned, and maybe depending on the context is not important, is the financial aspect, if they are covered or not. Is this something maybe I would like to learn in the US? Is this covered, and is that an impediment for influenza vaccination? And what's the situation in Latin America?
In the United States, flu vaccines are covered by almost all of the insurances. And in the programs we do, if a person doesn't have insurance, we just give them the flu vaccine. Oftentimes we will have a grant to support the activity. Clearly, if a person is in the hospital as part of the bundle of the payment for the hospitalization, it will be included. And most of the time, unfortunately, if the patient's being seen in a doctor's office, there is some insurance that's attached to that. So it really is not as big a barrier as it is, for instance, for the SGLT2 inhibitors or some of the devices or some of the branded medicines for anticoagulation. I don't think that the cost is the barrier. The barrier is overcoming the misinformation that vaccines don't work or that there's some way that they're actually harmful to you. And that's the struggle that we have across medicine, not just with flu vaccination, COVID-19 immunization, statins. It's a big problem. So if I had to put my finger on it, I would say that cost is not the main barrier, that the main barrier is understanding and action.
Particularly in Latin America and in other parts of the world, the cost is at the present time a barrier. You know, when you analyze for example, the inclusion of the vaccines in the list of essential medication in different parts of the world, including Latin America, we have the opportunity to check all the list of essential medication in many different regions all over the world, and in the average, only 40% of the countries have the vaccines into the list of essential medicines, and this is a tremendous information, because when this kind of medication have not in the list, the access is not free, okay? And this represent in many different parts of the world represent at the present time a barrier, an important barrier, yeah.
I mean, it sounds like that's a advocacy issue for WHF, right? Because if we're talking about all the risk, and if cardiovascular disease is the biggest risk now, and then it should be an essential medicine in every country, and that should be something that, and as I'm sure it is, with WHF as a major advocacy issue for parts of the world that really need, when you think about underserved or underdeveloped countries, middle-income countries who are struggling with healthcare expenditures, and you think about, goes back to what you talked about earlier with risk reduction. So if you think of the cost of treating hypertension for a year versus a single shot, I mean, it would be I can't think of an economist who could say there wasn't more value in that. And so when you're talking about the money that a country is going to spend on healthcare expenditures, it would seem to be a relatively easy argument to spend it on flu vaccines, especially in the very high-risk patients who are going to use the most resources if they don't do well. And so, I think that's a call to action to all of us in our own countries and for WHF as a organization.
Thank you. And I have one more question, and then I'll open to the audience. It was mentioned briefly about COVID, and I'm curious to hear from you, what was the impact of COVID regarding influenza vaccination in a positive or negative way, in your experience?
I'll answer your question, and I'll give you a little history, because we're here in New Orleans. There was a paradoxical increase in influenza vaccination when there was COVID vaccination, because people were now coming in. We would do both at the same time. The CDC in the United States says you can do them both at the same time. So there was, with this terrible pandemic, there was that benefit of an actual uptake. Although it was not as good as it should be, it still was only 40% in the African American community, better than 25, 30%. So the history I'm going to give you that you can take back to your places of home is that New Orleans was one of the epicenters for the pandemic in the United States. You heard about New York and the horrible things that happened there. You heard about Seattle because it's one of the main ports for airplanes that came from China. New Orleans was also a very hot center because on February 25th of 2020, we had Mardi Gras. And although this is a small city, for Mardi Gras, there are 300 to 400,000 people in the street densely packed. They come from all over the world. So we had our first case in March, and we were very heavily hit in the spring of 2020. So we are very sensitive to that, and it's one of the reasons we had already embraced immunization as part of the community health outreach that we were doing. But for this season and the season right after COVID hit, when COVID was first had influenza and COVID vaccine were given together, would have been in the fall of 2021, December, we embraced it because we were terribly, terribly hit by influenza. One other point I want to bring, especially for the younger members of the audience, August 29th, 2005, New Orleans collapsed. 80% of the city was flooded, 1,500 people died. And in a small city, if we were New York City or we were Buenos Aires, it would be like 30,000 people dying in one day. So we're pleased to have you here, but you need to recognize that this is a place where you have one of the worst disasters. In the United States, we like to bury that history, but it was not a minor thing. It almost killed the city.
Thank you, Kit. I don't know, Eileen, any other comment on regarding COVID and influenza?
You know, I think most people would agree COVID was the best of times and the worst of times in terms of the things that we learned. We were able to mobilize very quickly. The stressors on the healthcare system were phenomenal. In some ways, it was good because it really educated people about what vaccines are. I think prior to that, people would just get vaccinated because the doctor said so and didn't really have any concept of it. And because there was so much disinformation about COVID, there was a lot of effort by everyone in the healthcare environment anyway, not social media and all the other people who spewed all the nonsense, to try and make sure that people understood what a vaccine was, how they were developed, how were they chosen. And so it gave some increased understanding around flu vaccine as well. And so I think that part of COVID was positive. I think the COVID vaccine was so politicized that it has still today a very negative connotation, especially in the US. And for some reason, flu vaccine has escaped that, thank God, for the most part. People didn't sort of lump those two together, and so people are still coming now this season and last season to get the flu vaccine and weren't, spewing nastiness at you in clinic because you said, do you want to be vaccinated? So I don't know what the dichotomy was, but I do think the education that resulted around COVID, around vaccines in general, was very helpful because it was so prevalent. You couldn't go anywhere without them explaining what, the different types of vaccine were. So I think that was positive.
In our region, we observed two different periods. The first part of the 2020, in the first part of the pandemic, the vaccination rates for influenza was very low, very, very low, because during the lockdown and in this period, really the vaccination rate, when you check what happened in many different countries, really the vaccination rate was very low. But really one interesting observation that that during that time, the circulation of influenza virus was very low too, and don't represent a very important problem. And in the second part, in 2021, I agree that in our region, obviously the information about the COVID vaccines and the tremendous impact all over the world have a very interesting result in terms of in the hesitancy of the people related to the vaccines, no? And we have there is a very interesting change in the vision of the people about the vaccines, no?
Thank you. So your opportunity. You have 3 world experts on this. I hope you take advantage and you can ask questions to them.
So hello, my name is Roland de Jong from Amsterdam. I'm curious as to is the vaccination available in your country like year round, or what do you what type of types of influenza do you base your vaccination on?
Who wants to take that?
So the vaccination, the CDC decides what it's going to be for the season. They look at what they think the prevalence or what strain is going to hit, and so then they make a decision about what the flu vaccine. It's usually available in the fall through the winter, and so, but there is flu vaccine generally around for a long period of time.
I'm asking because we in the Netherlands we have a very strong cycle of fall and winter, and then no cases of flu in the summer. So we base it on what comes from Asia and just comes towards us. But we just have a very small window of vaccination for everyone to make sure that you have a vaccination on time, because it rises already in November and it will leave in February or something. So the window of opportunity is very small. So if your advocacy for vaccination for every patient in an or out clinic, so you will do this year round or also in this smaller window?
Yeah, not year round, but our windows are larger. The CDC actually suggests that you can start in early fall, September, and extend it all the way to the spring. So here in New Orleans, where it's springtime, even though it's winter up north in the United States, it's spring here, we still get influenza. So our vaccination will extend probably into April easily. We're not doing as many community outreach efforts now because we did those mainly in October, November, and in early January, where you get most cases. But the CDC clearly says that in the United States you should extend it into the spring.
Just a brief comment. Very interesting question, and because when you analyze the information, for example, in randomized clinical trials, in patients with, for example, with the heart failure, very recently were published the IBBI trial from Dr. Love and from McMaster, and really it's very interesting that you give vaccination flu independent of the sessional time. There is no impact in terms of reduction of cardiovascular disease. But when you analyze, when you prescribe vaccination during the sessional time, there is a clear reduction in cardiovascular mortality and total mortality. However, when you analyze other clinical trials, like the YAMI trials, this is the trial that I mentioned before related to acute myocardial infarction, it's very interesting that in this trial, 2,500 patients received vaccines independent of the sessional time, and the impact in terms of mortality was incredible. Really was amazing, was very important. 50% reduction in the exploratory meta-analysis, 50% reduction in total mortality in this kind of population, independent of the sessional time. Really, as in a logical perspective, the indication will be in the previous winter time. But really, in my opinion, it's an open question.
I can accept the data as you describe it, and it makes sense, and it's something we should look at. In the patient who's having an acute event, the inflammatory response, as I mentioned, with colchicine has shown some benefit. So in that particular setting, you're not doing a public health intervention. You're treating an acute inflammatory response in a high-risk patient. But across the population, clearly, we don't do immunization. In the United States, to work in a hospital, I don't know how it is in Florida, but here in New Orleans, you must be immunized, or you have to have a special sticker on your identification badge that says that you have not been immunized, and you have to keep a mask on at all times. I can tell you 90+% of the doctors, nurses, pharmacists, technicians, they're just going to get the immunization. So it's very, very high, but it's done for a limited period in the hospital setting. We don't do it throughout the year.
Just in the same way that Professor Ferdinand said, that it's very interesting that when you analyze this trial, the curves was separated very, very early. And really other open question is, what is the mechanism involved in this very, very early impact results? And maybe the anti-inflammatory process will be the answer, no? But really it's an open question too. And it's very interesting point of view.
Any other question from the audience? No, I cannot see any hand. I mean, one thing I want to come back, Elin, you mentioned about misinformation or disinformation, and of course that's something, I mean, we are all experiencing at every level in our society, and it's getting worse and worse. How we combat that? I mean, what is happening, at least in the U.S., and I know, Alvaro, you also have some interest in how we can use social media for, if you want, for the good purpose. Any thought, any reflection on these?
I don't know the answer to that question because in my mind, when I hear some of the rhetoric, I think to myself, how could you possibly even think that's a thing, or that's, you know, and the real problem is when people in power, in politics, make something a political issue, then people will align based on their politics, which has nothing to do with science whatsoever. And just watching that whole debacle and watching public health people be threatened with their lives during the pandemic because of the rhetoric that went along party lines, it was just inconceivable to me. And I kept thinking to myself, when is the common sense and the science going to trump? But I shouldn't have said that. When is that going to be what it should be, you know? And the problem in the United States particularly, and I can't speak for the rest of the world, but our social media, our quote-unquote news is no longer news. It's all rhetoric. And so it's very hard to find information because it doesn't matter which side you're on. All of the internet, all of that stuff, you know, when you Google, they're pushing you to the side of the view you have. They're not giving you a balanced view. They send you to the side they know you want to be on. And so it's a self-fulfilling prophecy of information because everything validates what you do because that's where they send you. They don't send you to the other side to say, whoa, look at the other side of the argument. And as long as the news media is no longer news, but is this whole agenda, it's going to be very difficult. But I think it makes it much more important that scientists are vocal, that they put the science out, and we're not very good about educating patients. We, you know, at this meeting, there will be lots of publications about late breakers, and we're at the mercy of whatever the press corps decides is going to be the soundbite from whatever. And your office practice is going to get 1,000 phone calls depending on what was presented here and how it was presented. How many of you got a call about aspirin in a prevention, when the guidelines came out about aspirin and prevention? All of your secondary prevention patients called and said, oh gosh, I don't need to take aspirin anymore. And it's how it was presented. And so I don't know how you make common sense and civility come back into a culture and a society.
And I don't know either. but I do think it is the problem of this century. We used to have a higher respect for the medical profession, the nursing profession, pharmacists, etc. I still think the respect is there. But now anyone who has any opinion can tweet or do a Facebook post or an Instagram post, and it can be picked up like fire and spread. One of the solutions is to do what we're doing right now, and that is those of us who come to organized environments and are members of nonprofit educational societies like the World Health Federation, the American College of Cardiology, Preventive Nurses, Cardiac Nurses Association. We should make sure that we have easy, digestible patient information. At the ACC, they have something called CardioSmart. They use infographics, cartoons. The font is nice and sizable for older people to see. And all of us should support those educational efforts. And when we are on social media versus answering back to some of the crazy stuff, post what's coming out of your organizations in terms of new material or new data. Hopefully that will make some dent on the wildfire of misinformation. But for me, it's very depressing to see how a person can just make up something and it gets 10,000 likes in an hour.
Alvaro, you want to add anything?
No, it's a very important and complex problem, no? I think so. Obviously, we need information, but information is not enough. Absolutely. The education is very important, and give the information to the population is the first step, but obviously it's not enough. The one important point is how is the message, how you build the message. Because it's very interesting that when you analyze the hesitancy of the population related to the immunization in general, and particularly with influenza, the people with high level of education have a high level of hesitancy. It's incredible. This is the truth, no? And this represents a very important challenges. The form that you give the information and the form that you build the message, because the message will be very different to the kind of population that you want to give the message. No, it's very different. The people with cardiovascular disease is very different. The people, the young people is very different. The older people, and as you mentioned before, the social media, the fake news related to the vaccines are a very impressive problem. There's a lot of many papers that clearly represent that have a tremendous impact in terms of hesitancy, one fake news. And maybe one fake news destroy a message that you want to make during the many times. No, it's complex, but I think our responsibility are centered in obviously in education and make the communication ways with the population. No, I think so, but it's complex.
Yeah, I mean, I know it's a difficult question, but I think it's an important one, and I think I agree that it's becoming more and more of a problem. We cannot hide that problem. I mean, we need to confront it in some way. At WHF, definitely, we have a very strong communication team, and we'll work on social media, and we need to find out how to counter these messages. We cannot ignore them. And for people like us, that, you know, we are very rational, we look at the evidence, and yeah, people are saying that the Earth is flat. You know, I mean, there are a large group saying that. Of course, I mean, from that you can assume that they might be.
Push them off.
Yeah. Well, I think at least for me, the initial reaction is always kind of, I'm angry. I mean, I say, why? I mean, it doesn't make any sense. But I think we need to overcome that and see what are the most effective ways, even using social media. And I think we do that, and understanding how to counter these messages.